Hello, and thank you for joining the National Pancreas Foundation and viewing our webinar. My name is Jenny Pagel-Guile, and I am the Executive Director. The mission of the National Pancreas Foundation is unique in that we focus on all forms of pancreatic disease, providing support for the medical professionals, the care providers, and the patients. Through our work, we have awarded over $5 million in research grants, provided endorsement for centers of excellence across the country, and provide over 30 programs for community members, medical professionals, in addition to just this webinar. First, I would like to share some more information about other opportunities to be involved with the National Pancreas Foundation. If you are a runner or know someone that is, we offer bibs and fundraising opportunities for various events across the country, be it marathons, half marathons, or those coveted bibs. Additionally, we have many more events that change, and they can be found on our website under the events calendar, pancreasfoundation.org/events. This could be a gala, a webinar, or a community chapter event. Feel free to follow along and sign up for our webinars on our website as well. Also, if you're looking to take a more active role, we have chapters across the country. Currently, we have approximately 30 chapters in many states. These chapter volunteers are vital to our grassroots opportunities. They table at health fairs, different community events, and share information. They host Pancreas Bowl events or other fundraising opportunities. They serve as advocates at the local, national, and state level. And they also provide other resources to our community members by being a voice of reason and also a peer in the community. If you'd like to reach out to Cheyenne to learn how you can make a difference in your community, her email is on this slide as well. Also, to stay up to date on the latest information, follow us on social media. We are found on Facebook, Instagram, X, and also on other forms as well. The Exocrine Pancreatic Insufficiency, the ins and outs of diagnosis and treatment of EPI in children, is hosted today by Dr. Jefferson N. Brunel. He is the co-director of the Pancreatic Disorders Program and an attending physician with the Division of Gastroenterology, Hepatology, and Nutrition at Children's Hospital of Philadelphia. He has additional training in pharmacology and nutrition, and his clinical practice focuses on the nutritional management of pancreatic disorders in children. Thank you, Dr. Brunel.
Thank you, Jenny, for that fantastic introduction. I'm Jefferson Brownell. I'm one of the directors of the Pancreatic Disorders Program at Children's Hospital of Philadelphia in Philadelphia, Pennsylvania. And today I'm talking about exocrine pancreatic insufficiency, specifically diagnosing and treating it in children. And the objectives today, I want everyone to be able to understand the pathophysiology that underlines EPI, know who, when, why, and how to evaluate for it. And then I want you to be able to competently start treating somebody. So essentially, we're going to talk about what works and what doesn't work, talk about a clinical approach, and then honestly, my objective is to convince you that EPI in kids is different than adults. And also, I want you to be equipped to be able to investigate it and treat it if you uncover it. So to do that, we're going to talk about exocrine pancreatic sufficiency and insufficiency, talk about some of the different tests you can do, specifically touching on endoscopic pancreatic function tests and magnetic resonance imaging, and then we'll talk about treatment. So to quickly review pancreatic sufficiency, because we have to know what's normal before we talk about what's abnormal, you know the structure of the pancreas. The exocrine pancreas, you have acinar cells and duct cells. Acinar cells being where enzymes are produced, and then duct cells being where sodium and bicarbonate are secreted, and along with that, water. And all of this comes together to make the pancreatic juices. Of course, there's also the endocrine part of the pancreas that secretes hormones, most famously insulin and glucagon, a number of other ones as well. And then one thing that is not often remembered is that the pancreas has actually got its own little tiny portal system. So you have arterioles that come in, pass through the islets of Langerhans where the endocrine cells are, which is where the insulin and glucagon are secreted. And then that blood then flows over the exocrine tissue, so where the acinar and duct cells are. And so you actually get, I kind of think about the insulin being the fertilizer that's feeding the garden that is the exocrine pancreas. So your pancreatic enzymes, we talked about being produced in the acinar cells. Essentially, these are breaking down your macronutrients. All your peptidases, like trypsin, chymotrypsin, are breaking down proteins. You have amylases that break down starches, and lipases that break down fats. What's always fascinating, we focus so much on fat. Fat malabsorption is the main causes some of the main symptoms of exocrine pancreatic insufficiency that we'll talk about soon. But in reality, lipases that are breaking down fats are only up to about 5% of your total enzymatic secretion from the pancreas. Most of it is actually to digest proteins and then a little bit of starches as well. So the lipases, though, that come from the pancreas, even though they're a small percentage of the overall secretions, they're really effective. So only 100 milliliters of fluid from the duodenum, so less than half a cup, contains enough lipase to digest your entire daily fat intake in about a minute or so. So you can actually lose a lot of your exocrine tissue and still digest fat adequately because you have plenty in there. And so the pancreas is under the control of a few different hormones. So when you have acid in the duodenum, pictured on the right is these little yellow balloons. That's going to stimulate secretin secretion from the S cells in the duodenum. Secretin has a number of local functions. So it's supposed to increase the duodenal pH, so neutralizing stomach acid, which it does that by stimulating bicarbonate and sodium secretion from the pancreatic duct cells. So and also bicarbonate and sodium secretion from Brunner's glands in the duodenum. So when stomach contents pass into the small intestine, the acidity stimulates the flow of pancreatic juices, as well as some duodenal juices as well. Also, acid secretion locally in the stomach is inhibited by secretin. Bile production and insulin secretion also stimulated. So all that kind of makes sense. You've got stuff in the small intestine, so all of this, everything necessary for digestion is being stimulated. So you also have another hormone that's secreted in response to proteins and fats in the duodenum, and that is CCK, or cholecystokinin. So cholecystokinin has a number of functions as well. So it actually stimulates the release of the proenzyme granules from the acinar cells. So it's also going to inhibit gastric emptying and stimulate the release of bile. It's, famously what we use it for in medical testing, because it stimulates contraction of the gallbladder, relaxation of the sphincter of Oddi. So together, you can see how CCK and secretin are stimulating the pancreas to secrete all of its main things. So CCK with the acinar cells, secretin with the ductal cells. And then once, under normal conditions, when the pancreatic juices are in the duodenum, then the triglycerides are digested down into their free fatty acid and acetylglycerol constituents, and then mixed together with bile salts to be emulsified into micelles and absorbed at the brush border of the intestine. So that is how you get your normal digestion. And I remind you of that just because, as we'll talk about later, when you're thinking about EPI and what's going on, you think about what's going on in the pancreas, but also in the intestine as well. So back to our little acinar ductal unit here. So we talked about function, now we talk about dysfunction, when everything's not working. Fortunately, your body has some compensatory mechanisms for this. So even though you're not secreting all those peptidases from the pancreas necessarily or enough, you have gastric pepsin and a few proteases in the lining of the duodenum that can kind of take over some of the protein digestion piece of things. You have salivary amylase that can take over the starch digestion from, if your pancreas isn't secreting amylases. And then, of course, the big question is with fats. So you do make lingual lipase, particularly as an infant, and you make a gastric lipase as well. But there is a difference among all of these different lipases. And so pancreatic lipase is the most efficient. It indiscriminately targets fatty acids, and whereas the lingual lipase is going to really target short chain fatty acids, which makes sense because that's predominantly what's in breast milk. That's why it's more common in infants. And then gastric lipase seems to target short and medium chain fatty acids not very well. And also, it actually probably has more of a role in motility and maintaining your intestinal motility homeostasis rather than actually digesting fat. So pancreatic lipase is also going to be active at a higher pH than like your lingual lipase is, and a higher pH than the stomach. So just to further illustrate the efficiency, so gastric lipase is going to cleave one free fatty acid off of your triglyceride, which means you have one free fatty acid to be absorbed, as opposed to pancreatic lipase, which cleaves two fatty acids off. So even if you had a ton of gastric lipase to try and take over for the pancreatic lipase, it's still not going to be nearly as efficient at digesting the fat for absorption. What are symptoms of exocrine pancreatic insufficiency? This is a little picture from the Identify EPI website that a company has put out that has a number of symptoms listed on it. So steatorrhea, or fatty diarrhea, is the most famous one, again from fat malabsorption. Frequent defecation after eating, very foul-smelling stools, flatulence, abdominal pain, which may or may not be associated with eating, honestly, voracious appetite, and then typically more associated with cystic fibrosis is rectal prolapse. And one thing you'll notice about these symptoms is that they're all relatively nonspecific GI symptoms. And so this can be a little problematic when patients have these symptoms that aren't necessarily, outside of steatorrhea pointing towards any one specific diagnosis. It can really prolong the time it takes them to actually get diagnosed and treated. And you don't necessarily have to have all of these symptoms either. As we'll talk about later, pancreatic function is on a spectrum. It's not just a switch that goes off or on. One thing that comes up a lot, actually, that I want to have a little aside about is floating stool. So that seems to be a question that people associate floating stools with there being a lot of fat in it. This guy, actually, Michael Levitt, won an Ig Nobel Prize for investigating what it is that makes stool float, and discovered essentially that it is really air in the stool and not fat. He put them in vacuum tubes and sucked all the air out, and then the stools sank, even if they were fatty. And he concluded, ultimately did the math, that it would take a whole lot more fat to actually buoy the stool and make it float. So floating stools themselves, not necessarily a sign of steatorrhea, but I put the citation up there if you want to explore it further. So back to our symptoms of EPI. So in addition to those more general symptoms, you can have some that are a little more specific to the nutrients that you're not absorbing. So remember, in those micelles, along with the free fatty acids and the bile salts, you have cholesterol, you have choline, fat-soluble vitamins, important things in there. So if you're not absorbing those, you have energy losses from not getting all that fat, which is going to lead in a child to poor weight gain or even weight loss, and over time, linear growth, falling off the curve or stunting. Along with the calorie deficit, you also may not be absorbing fat-soluble vitamins as well. So with vitamin K deficiency, you can have easy bruising and bleeding. Long-standing vitamin A deficiency can lead to poor night vision. Vitamin E deficiency can lead to decreased proprioception and paresthesias. Vitamin K, vitamin D, vitamin A all have roles in maintaining bone health, and so fractures or decreased bone density can be associated. So because, remember, one of the other jobs, we have to not always just think about enzymes, but have to think about how the pancreas also neutralizes stomach acid too. And that basic environment in the duodenum is necessary in the absorption of vitamin B12. So if you have a B12 deficiency, you can get anemia, macrocytic anemia, neurological defects associated with it. And then if you're not digesting and absorbing your long-chain fats, you can become, over time, deficient in your essential fatty acids, which then would result in rashes, poor hair growth or hair loss, and in a younger developing child, developmental delay. So one of the big differences between adults and children is, what the cause of EPI is going to be. So really, when you think about the different causes of EPI, whether you're a pediatrician versus an adult doctor, usually you're going into it thinking about different things. So, across the lifespan, you have some of the genetic disorders like cystic fibrosis or Shwachman-Diamond syndrome, where, cystic fibrosis, not everyone has it at birth, but by age 5, a large percentage of people with specific mutations will have pancreatic insufficiency if they're not started on modulators. Kids with Shwachman-Diamond syndrome can be born with it, and then some will outgrow it over time. But obviously, even if you're an adult specialist and someone has cystic fibrosis or Shwachman-Diamond, you'll always be thinking about EPI, but it's going to arise early on in childhood. Malnutrition is one that's a lot more commonly associated with causing EPI in younger people than older people. Malnutrition without an underlying cause, because then older people, you're going to think more about pancreatic cancer. Chronic pancreatitis, unfortunately, as we know, can pop up really just about any time in life, but is a major cause of EPI. And then there's things that can happen, well, and then surgeries too. Surgeons taking it out. Hopefully that's happening as people get older and not younger, but in the era of TPITs and pancreatic resections for other reasons, you might see that in younger people as well. So of course, across the lifespan, there's also, transient causes of EPI, whether it's like a post-infectious or, post-pancreatitis sort of event. And then celiac disease can pop up at any time. I always love to remind everybody that you can always have to think about celiac disease, no matter what other GI diagnosis you're talking about. But one thing that's important is these are all pancreas-based etiologies. So these are all some dysfunction of the pancreas. And so when I'm talking to patients, I actually kind of go back to basics and think about like, all right, with the symptoms of EPI, essentially you're going to be there because there's not enough enzymes, right? So anything that decreases enzyme production can cause EPI. So that can be chronic pancreatitis, reducing the number of acinar cells you have to make enzymes. Malnutrition, we brought up earlier, your body, it's kind of a paradoxical reaction, doesn't produce as much enzyme in a malnourished state. And then surgery obviously reduces acinar volumes. But then in addition to, those causes, what if you have plenty of acinar tissue? Then you think about things that are keeping enzymes from being active when they're in the intestine. So are they not getting there because of some sort of ductal obstruction? Once the enzymes are in the intestine along the brush border here, are they not being activated by enterokinase? Is there inflammation in the brush border that's led to that's reduced the amount of enterokinase that's there to activate the enzymes? And then, okay, so maybe you have enough enzymes, they're making it to where they're supposed to be, but then for some reason they're being inactivated too early. So remember we said they're active in a pH from 4 to 6. If you still have stomach acid that's at a lower pH between 2 and 3.5 or so, those enzymes are going to be deactivated pretty quickly. So how do we diagnose EPI? So there are indirect tests and direct tests that are essentially a balance between tests that are perhaps not as exact, but are much less invasive. The indirect tests, which look for, you're not actually measuring, so a direct test, you're measuring what's coming out of the pancreas itself, whether that is, with one of these tubes or a scope, you're actually measuring the amount of enzyme, or with an MRCP, you're quantifying the fluid that's coming out, versus an indirect test where you're essentially evaluating a surrogate, saying that if this, test is abnormal, it means there probably is abnormal pancreatic function. So we'll talk about some of these in a little more detail. Have to talk about the coefficient of fat absorption because it is the gold standard test for dietary fat malabsorption, required in research settings. So if you are a drug manufacturer and you want to bring a new enzyme to market, you say it's going to be treating dietary fat malabsorption from exocrine pancreatic insufficiency, you have to show that it affects the coefficient of fat absorption. So typically this test occurs over 72 hours, requires 72-hour collection of dietary intakes as well as stool collection. Then you essentially are figuring out the percentage of fat that's in the diet that is then not coming out in the stool, that's being absorbed. It's a simple equation. And so infants actually have malabsorb a greater amount of stool or of fat than toddlers and older children. So normal is above 93%. So 9/10 of the fat that you're taking in, you're absorbing. Problem is, this test is pretty labor intensive, can be difficult to obtain in children especially, well, teenagers especially. It can be really difficult to convince someone to actually poop into this and then keep it in their freezer for 3 days before bringing it back. You also have to collect a very detailed diet history, which is actually quite hard to do. Also, to improve accuracy, although this is somewhat debatable, patients should be on a kind of a higher fat diet for it to be accurate, which is a little unfortunate because in a lot of cases, people have realized that fat is what's causing their symptoms and they want to avoid it, and then you're making them consume this thing that could be causing some symptoms. Also, kind of worse, it's not specific for EPI. So anything that is causing fat malabsorption. So if you have liver disease and you're not secreting bile acids and not making those micelles for absorption, if you have inflammation in your intestine that is causing a malabsorption, you're going to be malabsorbing fat. And so this will be positive or show fat malabsorption even in other conditions besides EPI. So fecal elastase tends to be the indirect test of choice. So it's a protease that's specific to the pancreas. It's not degraded in the intestine. And it actually does not cross-react with any of the oral enzymes, so you can do the test in somebody who's taking enzymes. Typical cutoff is less than 200 micrograms per gram of stool, so that's a concentration. I'm always curious, where we get our normal test values from, and this was actually from a test in the late 90s, or a study in the late 90s, where they looked at 28 patients with cystic fibrosis, so they divided into 3 tiers based on how exocrine insufficient they thought they were, and essentially compared an elastase, the coefficient of fat absorption, and direct pancreatic function testing. And essentially that's how they arrived at the cutoff of 200. Some places, so here, we will say it's abnormal if it's below 200. If it's between 200 and 500, we do kind of wonder a little bit and think it might need a little bit of investigation, but really less than 200 tends to be the norm. And so I, was thinking, all right, well, is this actually generalizable externally? As has been shown in the literature, but I'm stubborn and I like to look at these things myself. And so I went back to the original table where they compared steatorrhea to fecal elastase, and then I did the same thing with a cohort of patients or subjects I had for a research study, and everything almost matched up exactly. It was fascinating. So good things about the elastase, in addition to being pretty valid. It's not very expensive. It only requires a gram of stool, so not 3 buckets or multiple buckets of stool like a coefficient of fat absorption. And it's not going to be affected by the diet or whether someone's fasting. So, regardless of what their fat intake is, this test is still going to be the same. Cons, there's some variability in assays made by different companies. Still does require stool. And then if the stool samples are dilute at all, that can affect accuracy. So I mentioned a second ago that it's a concentration, so micrograms per gram of stool. If your stool is very dilute, then your elastase may look falsely low. So this is the point where I always kind of want to step back and say, so we're talking about pancreatic insufficiency. We've kind of talked about what the normal function is, the conditions under which EPI happens, and what the symptoms are that it causes. But what actually is exocrine pancreatic insufficiency? Like, how do you actually define it? Is it just someone who has an elastase less than 200 micrograms? And then what about the other enzymes? If someone's deficient in those, what has a normal elastase? Does it have to do, can we include people who don't secrete enough bicarbonate from their pancreas and thus don't neutralize the stomach acid and enzymes get deactivated? Is it just people who have symptoms of malabsorption or steatorrhea? Some people may get this reference with the Honorable Justice Potter Stewart, who in a very famous Supreme Court decision in the United States was asked how he knew something was, and he said, well, I just know it when I see it. And that seems to be kind of our attitude sometimes, except, we're not that great at actually diagnosing EPI. The most general definition that you will see from paper to paper, essentially insufficient pancreatic secretion resulting in malabsorption. And to the frustration of some of our colleagues, we don't really have any clear criteria. So, Dr. Trout trying to, establish what EPI looks like on an MRI, keeps coming back to us and always kind of makes me laugh a little bit and says, well, how are you defining EPI? So the reality is, as I mentioned before, pancreatic function is on a spectrum between 100% and 0%. Symptoms might pop up at different degrees of pancreatic function and in different people. So, you may have a reduction of up to 80% of your pancreatic function, but your tests are probably going to be normal. You probably don't have any symptoms. You might start to develop symptoms at some point. Again, it depends on the person and what it is that, what part of the pancreas is not functioning. And as function starts to drop off, usually irreversibly, you might start to see some abnormal tests. You might have some more variable symptoms, but then, we know tests are going to be abnormal when pancreatic function is almost gone. And of course, then the symptoms become a little more obvious. And so the question that, my colleagues are always asking is, so in a patient with diarrhea, say, or like, one or two of those symptoms on the list, should we send an elastase? Should we screen for EPI? And so I always think it's a good principle to go back to the basics of testing that we learn in med school, grad school, nursing school, and like, when should you actually order a test? And, this is based off of the sensitivity and specificity. I won't get too deep into those and be pedantic, but, there are meta-analyses and systematic reviews that actually look at the sensitivity and specificity of elastase in detecting EPI, with actually a pretty, substantial number of studies that they looked at, and essentially found that sensitivity, when you pool all this together, is about 77%, specificity 88%. So that's actually, relatively decent for a test. Then other factors go into it, though. So that's just the characteristics of the test. You also have your population that you're testing. So that's where positive and negative predictive value come into play. Like, what proportion of your results that are positive are actually positive in the population. So both of those are dependent on how prevalent this is. Unfortunately, we don't have great data on that outside of chronic pancreatitis. So another thing to think about is your pretest probability. So what's the probability that this patient actually has this condition before I'm testing? Is the test actually going to help me out? And so in this same paper, they looked at people who met criteria for IBS, which is a number of those same symptoms that we looked at before. Noted the false positive rate of an elastase is probably about 11%, true positive rate 4%. But reassuringly, if the test is normal, then the false negative rate is actually quite low, which is good in ruling out EPI in the population. So this makes elastase actually a pretty good screening test. If it's negative, you can be, or it's negative. If it's normal, if their elastase is greater than 200, you actually probably can be pretty sure that the patient doesn't have EPI. Problem then is this false positive rate that's relatively high. So this is where you can actually use those principles to try and say, all right, am I testing the right person? So one thing I always think about is, do they actually have a fatty diarrhea, or is it just regular diarrhea? So this is from an algorithm that has been published by Martin's group, essentially breaking down diarrhea when you see it into watery, fatty, bloody, because that's going to help you decide what test to order and what conditions to look for. Remembering that elastase can be diluted in patients who have watery diarrhea. So with an elastase, who are you using the test for? So let's say you do send it in someone with diarrhea and it comes back low. What's the next step? So, we have our kind of borderline yellow box on our algorithm, and then the red. But as the INSPIRE consortium has recommended that you have 2 low elastases before you actually diagnose someone with EPI, we say the same thing. So we recommend repeating it. And so then if you have 2 low elastases, you meet that suggested criteria, and then you can be pretty sure that it's not false positive both times, and you can start enzymes. I always also say, if you're going to repeat the elastase, this might be a good time to get other stool studies. A qualitative fecal fat, not always useful, but if you have, an increase in your fat malabsorption along with low elastase, you can be a little more sure that you're actually seeing someone with EPI. So if it is in a gray zone, there is a doubt about it, there's also the direct tests. So the main direct test right now is endoscopic pancreatic function testing. So with this, you can actually directly evaluate the acinar function and detect some specific enzyme deficiencies. The indications in children are going to be a little different than in adults. Definitely, evaluating for EPI in patients who have steatorrhea, chronic diarrhea, or failure to thrive. I would argue if they have steatorrhea and a low elastase, you probably don't actually need to do this test, because then your pretest probability would be so high that you're not necessarily learning anything new from it. One way that NASPGHAN recommends you use them, and that I find particularly useful, is to define what your pancreatic function is. It presumably can be a little more accurate, or if you're looking for specific enzyme deficiencies. NASPGHAN also recommends using it to rule out chronic pancreatitis in cases that are otherwise inconclusive. Also, if you know someone has fat malabsorption, you're trying to figure out exactly why. So the way this is done, as you can see in this graphic, is during an endoscopy, an upper endoscopy, you advance the scope in, suction out the stomach and the small intestine, and then you can administer secretin or CCK or both. and then collect the fluid that comes out of the pancreas and measure the enzymes at different time points. So this is the proposed protocol that from the NASPGHAN position paper in 2021, and used at most of the larger pancreatic centers around the country, giving secretin or CCK. I find it, we do both just because of the biological plausibility of, stimulating both the acinar cells and the ductal cells. There was a shortage of secretin about 25 years ago, and that there actually were head-to-head studies done where they compared just giving CCK to just secretin, and found that they were pretty comparable. No one's actually then done the comparison with secretin and CCK versus each one of those individually. So giving those and then measuring at multiple time points, your pancreatic enzyme secretion actually peaks pretty early on within the first 10 minutes or so. And so if you get normal complement of enzyme activity over one of these sample collections, then you know that you have adequate pancreatic function. Also, you usually are measuring the pH to make sure that your fluid is in the normal range, and also some places will collect bicarbonate as well. So the other direct test, well, I call it a direct test, is a secretin stimulated MRCP. So with this test, you can evaluate ductal function as opposed to acinar function by looking at the volume of fluid that's secreted after you administer secretin during an MRCP. And fortunately, that rush of fluid can actually give you some really good information about the anatomy. So you can see in the top left in this picture, there is some fluid in the duodenum before secretin is given. But then after you give it at 3, 7, 10 minutes, you can see the ducts of the pancreas fill up beautifully. So that's how you can see if there's any scarring or anything. And then you see the fluid go into the duodenum and make it, in this case, all the way around to the ligament of Treitz. And so you can estimate what their ductal function is, at least. You're not really getting any information about the acinar function. So the indications for this, obviously, would be to evaluate for EPI and evaluate your pancreatic anatomy. Should not do it in somebody who has active pancreatitis. So say you've done some of these tests, you've diagnosed somebody with EPI, so what are the next steps? Then you treat it with pancreatic enzyme replacement therapy. So different forms here on the screen. On the right, you have some examples of brand names, and that are capsules with the granules of the active enzyme inside them. The enzymes are enteric coated, so they should pass through the stomach without being deactivated by that stomach acid. And then the coating comes off when you get to a more basic pH. On the left, you have the uncoated pill Viocase, which in the United States is really only used in crushed up and mixed with enteral feeds. And then Relazorb or Relizorb, the enteral inline feeding cartridge, which just contains lipase. So these are all different ways that you can replace someone's pancreatic enzymes. How do you do it? Well, quite easy. You dose by the patient's weight or by the amount of fat they're taking. So weight-based dosing is used more often in children who are eating orally. It's less precise because you're essentially saying, well, for their body size, they probably need this much. That does make it a lot easier to adjust, to give the families a range of how much they can give. Versus fat-based dosing, which is more precise. You obviously have to know what the fat intake is, so that's why that method is used more frequently in patients who are, have enteral feeds where you know exactly what they're getting in their formula provision, or in newborns and infants who you know exactly what they're getting. One example of how variable a meal can be, I have borrowed from my friends in the Cystic Fibrosis Foundation. But essentially, you can see the variability in a meal. So spaghetti with sauce, only has 2 grams of fat. So you would, if you're doing fat-based dosing, you would give a capsule. Once you put a couple of tablespoons of butter, because what's not better without butter, then you greatly increase the amount of fat and you need more capsules. Then when you add meat and cheese, you can get quite a bit of additional fat there. And so someone who's on a weight-based dosing prescription, which might be like 4 capsules or something, might not necessarily adequately be matching up to the amount of fat that's being taken in. Another thing, once you've diagnosed somebody with EPI, is you need to follow their micronutrients. So remember, we listed off all the potential side effects or symptoms you could have from these nutrient deficiencies. So in the left column, you have the different nutrients and in bold, and then under them, the tests that you can use to evaluate them, blood tests, all of them. And then in the middle column, you have how essentially we treat when someone is deficient, and then monitoring in the third column. So we always check these labs when somebody is diagnosed with EPI. And then what if they're deficient and we're supplementing them actively, then we'll check a little more frequently. And then once they're back to normal, you can start to space out how often you're checking these labs. Because once you've corrected the deficiencies, as long as the EPI is being treated, usually you should be maintaining adequate serum concentrations of all these micronutrients. It is important to note, though, that if you note a deficiency, you can't just expect that giving someone pancreatic enzyme replacement therapy is going to correct the deficiency. You are going to improve the absorption efficiency of those nutrients, but if someone is deficient, they do actually need supplementation. So how do you know that your enzymes are working? So this is little information from our pathway that I put a QR code up for earlier. But essentially, how are you going to know that someone's enzymes are actually working if they have EPI? So honestly, in the short term, you actually should see some differences. If they have steatorrhea or looser stools, they should have improved consistency and frequency of stools. So, hopefully they're not having nearly as much pain or flatulence or the malodorous stools like we mentioned before. In the longer term, in infants and children, we are following their weight and their linear growth. So in infants, you would expect within about a week or so, they'll be back on the median growth velocity for their age. Older children, usually you'd expect in about a month or so that their weight would start to tick back up. Adults is a little harder for a pediatrician because they're, or adult-sized people, because we're not constantly looking for weight gain. But if we've stopped weight loss, then we feel pretty good about it. If you still have symptoms, obviously, you still have poor weight gain, still have poor linear growth, still have symptoms, then you say, all right, they're not responding to enzymes the way we think they should. So there are ways to troubleshoot that. So you can obviously make sure the patient is taking them. That's usually the first big thing to check on. One thing that's common in children is they'll get their enzymes and then, they pick at their food over the course of an hour, get up, go watch an episode of Bluey on TV, come back, 15 minutes later. And, their enzymes are only good for about 20 to 30 minutes. And so the tail end of that meal isn't necessarily going to be covered. And so that undigested fat can cause symptoms and, the things we're trying to treat. Enzymes are also very temperature sensitive, so having them in a place that's too hot, like a windowsill or a glove box, or too cold, like a cooler at the beach, can inactivate them. We have had one time in the famous shipping outage last year where UPS was down. Someone's enzymes, one of our patients' enzymes were compromised in the shipping process. And so, ways you can address it, you can adjust the dose. There's conflicting research about it, but generally pretty safe to add some sort of acid suppression, whether it's an H2RA or a PPI. Sometimes switching up the brand, one of those inexplicable reasons. Or then you have to start thinking about other causes, right? So if this is a patient who came to you and you diagnosed them with EPI based on the low elastase, whether you were totally sure about it or not, it's always helpful to step back and think about other things that can cause those same symptoms. Remember, they're not very specific. So always okay to take a step back and think about things. You could try repeating testing. So remember, an elastase is still valid in somebody who's on enzymes. Or if you diagnose them with an elastase and they just aren't responding as you've made all your adjustments, then maybe it is time for endoscopic pancreatic function testing, right? Because you can test what the state is of the enzymes as they're coming out of the pancreas. You also can evaluate the small intestine for inflammation or other causes. And it does kind of help you narrow down to where the problem is, right? Is it pancreas? Is it not being activated? Is it being deactivated? And just while you're doing this, obviously, you're trying to keep in mind quality of life, right? So yeah, that's what it comes down to at the end of the day. Sometimes it's better to just go ahead and default towards the diagnosis of EPI and treat someone with enzymes if it makes them feel better, especially kids who need to be growing, need to be eating, and those don't need to be, eating doesn't need to be a painful time for them. Then the balance of that too is, you have to take enzymes with every meal that contains fat, which often in growing children is a lot of them, or in someone who's malnourished and, they're on supplements. So you're introducing a substantial pill burden on somebody too. And so it is always good to kind of take a step back and make sure, all right, these are a pretty benign intervention, but do they need to be taking them? Are they actually helping? So that in general is the approach. Thank you everybody for listening. Here's our contact information if you would like it. Otherwise, we'll turn it back over to the NPS.